We'll have Akshay next, who's going to talk about EYELID.
Thank you, Dr. Surya, for inviting us to be a part of this. So I'm going to be a little more specific uh, with regards to eyelid, because I think eyelid tumors are already being considered separately. So this is more about red flags in ptosis. Uh, okay. So more of how the red flags are things that I picked up, which are either my mistakes or mistakes of others, or when we've tried new things. So I think as you keep doing and operating ptosis and seeing ptosis, the more you realize which ones are best left alone, and so you're able to identify the red flags more. I think the most important rule rather than a red flag is to document every patient at every visit. When you document, you're able to have proof of what you've spoken to the patient about. It also is a good idea to document and measure, check on the day of the surgery as well. And you always, because you've taken photographs, a patient's history may be a little inaccurate, but photos will never lie. So what do? I do on the pre-op, at least one visit pre-op, first day post-op, 1 week post-op at suture removal, and 3 weeks, and at every subsequent visit. If you have this also is such a kind of an insurance blanket against any patient-related dramas that may pop up later. Uh, this is like an index case, a patient with right congenital ptosis, and you would be tempted to do he's 618 in the right and the ptotic eye amblyopic. So one would be tempted to do a tarsofrontalis sing, but if you see it's an amblyopic eye, he's even at rest, he's not trying to elevate his frontalis. So you would almost be cursed with an undercorrected tarsofrontalis sling if you do that, because it doesn't work. So the next, again, rule rather than a red flag is in ptosis. You don't always need to do what the book says. If it's poor to severe ptosis with poor levator function, you almost always have to do a sling. You can be selective of the cases and figure out which patients are going to improve, especially in unilateral sling. And with the supramaximal levator resection available, you should harness the option of that to get better results for the patients. So the third red flag, or again, is Marcus gun jaw winking phenomenon. Now you can see that in the patient on the left, the Marcus gun is correcting itself to the height of the ptosis, height of the contralateral normal eyelid, as opposed to something that is going higher up in the kid. So the, if you have a one-stop solution for all Marcus gun jaw winking phenomenon, you're likely going to have every alternate patient who's going to be unhappy, because with a hammer in your hand, everything that you see is going to look like a nail. So I always ask the patients, is it the drooping that bothers you or the eyelid movements? And even if the Marcus gun jaw winking may be severe, but patient is not bothered about it and they want only the ptosis to be addressed, do that, because ptosis is so much of a cosmetic surgery that uh, giving the patient what they want is the best outcome that you can have. Again, so case 4, this is a 2-year-old girl accompanied by the father, and father says that left eye is the smaller, is been small since childhood. And then the mother joined in and said, nonsense, the left eye is just today, but usually it's the right eye. And father and mother were having a fight. Anyway, I saw it looked like a congenital left ptosis, so we planned a left levator resection. And on the day of the surgery, that's how the child came. So it's a 3-year-old child, and you're wondering what was. Then you could realize why the parents were confused. It turned out to be because of our documentation rule. You could compare, and the child turned out to have a thymoma and was anti-acetylcholine receptor antibodies positive. 10% of all patients who present with ocular myasthenia have a thymoma at presentation under the age of 40. So there's a 1 in 10 chance that in a young myasthenic you may actually pick up a thymoma. So a CT chest, either you can request it or get it done by a neurologist, is important, especially in myasthenias who are diagnosed under the age of 40. So red flag for the next one is this 73-year-old male with a recent history of trauma, diplopia. The ocular motility is restricted in all gazes. There is ptosis and restriction in most gazes. An MRI brain was done, and my squint colleague said this is a partial third nerve palsy, and we let it be. But there was something unusual about it. So all we did was an ice test for 5 minutes, and you could see his motility had completely improved and come back to normal. So ice is nice, myasthenia is not. So a well done ice test is always a good thing. Few pearls on how not to go wrong with an ice test is to keep it for a minimum of 2 minutes, and do not keep it longer than 2 minutes, because you may then get a false negative. Too cold of a temperature on the eyelids inhibits the inherent contractility. So, in a patient whom you would normally get an ice test positive, because of you now having kept for ice too long, the muscle is not able to contract and you get a false negative. So, no more than 2 minutes if you're assessing ptosis. However, if you're assessing ocular motility, you need the low temperature to spread around. So, 5 minutes is the recommended time for assessing the ice test outcome in ocular motility. So there again, document before and after, and a 2 millimeter improvement in the eyelid height is considered to be a positive ice test. So this is the next red flag: a 43-year-old female with a history of a slap, domestic violence, blurred vision, and ptosis. An MRI and MRA was done elsewhere and was diagnosed as a third nerve palsy and was put on oral steroids. This was when we saw her. Now, having imaging done with an MRA also done clears you of what Dr. Rashmin presented and told us what you should not miss. So now it was isolated to be an eyelid issue. We did nothing and just waited. In 3 months' time, it was almost up, and in 6 months' time, she was near normal. So in traumatic ptosis, don't jump the gun. Time is your friend. If there's trauma, wait for at least 6 months. Even a cataract surgery or a VR surgery or any procedure where the speculum has been placed to stretch the levator, wait for at least 6 months for some kind of spontaneous recovery before going in and operating again. There are videos with this, but I won't go too much into this. Going back to being flexible and not always sticking to one form of one approach of ptosis. If with careful selection based on your phenylephrine test, good cases of mild or moderate, even congenital cases, can be operated well with a posterior approach. I have personal reservations against Fasanella Savard, but I think the Conj MMCR is a very good option. So don't be afraid of the posterior approach, and with good selection, you may actually get good results. But master the anterior approach, because whether it's a primary ptosis surgery, and even if your posterior approach has failed, your anterior approach is your fallback option, because you're so familiar with the anatomy. So a lot of people, advise, even if you've done your anterior ptosis, that with a slight undercorrection or overcorrection, at 1 week on the Paracaine drops or topical anesthesia, you can revise. I strongly object, because it's not a comfortable feeling for the patient. And if you're going to revise, you might as well do it at least after a week and do it under local anesthesia. Even if you want to do it earlier, and if you've had good results, a little bit of local anesthesia is always better. I think revision under topical anesthesia is almost as bad as probing in office. The next red flag I'm going to talk about is paying attention to contour. No two ptosis patients are alike in height, in contour, in canthal position and laxity. So therefore, you can't do a single technique of placing your sutures, etc. So if you see this patient's contour, there's a clearly pronounced medial droop, as opposed to a generalized, almond shaped droop that you would expect. So in the case above, you want to make sure that your medial bite is deep, is strong, and is actually having an effect on the contour and not just the height. So a good way to do this is, when the patient is primary position sitting up preoperatively, mark the point on the eyelid which coincides with the pupil, and that way you will be able to pre-place your, it will be a pre-placed guide as to where to place your contour sutures on medial and lateral sides. The next red flag is about this 44-year-old diabetic who had ptosis since 4 years. She was investigated for myasthenia and thyroid, and everything looked okay. So we did an anterior approach, a levator resection in the left eye. And after the surgery, now obviously the right eye, in the right eye and the left eye, the herrings had unmasked the ptosis there. And again, the beauty of having documented, you can see that the brow position in the pre-op photo is also asymmetrical, giving you an indication that there was asymmetrical ptosis that should have been checked, and herrings should have been unmasked. Herrings phenomenon is real, and you have to counsel the patient and check for the eyebrow position and gently negate frontalis. And you again, patients may say that I don't have ptosis in both eyes; it's only one eye. But if you've got photos to show that, it helps. So this is another patient with ptosis in the left eye, and like Dr. Rashmin had mentioned, retraction on down gaze. And this is again a case of aberrant reinnervation. This is one of those cases where you do not want to go in and operate and try to check what you can improve on. So not all cases of ptosis must be operated upon. Just wait, watch, and decide what you want to be able to give. Red flag patients are, other red flags in your ptosis clinic are patients whose main complaint is the previous surgeons who she's visited, or patients who had multiple procedures are unsatisfied, and an obsessive approach with a mirror in their hand. They'll point out to possibly invisible problems that you cannot appreciate with unrealistic expectations. And once the surgery is decided, that too, flags like over familiarity and unnecessary praising, those are the kinds you want to avoid. And repeated cancellation of a surgical date over time also, I've realized, is a red flag. The patient is unsure and is probably going to be unconvinced of the outcome also. And wanting a picture of wanting to look like someone is a very common kind of request by the patients, which again is a red flag. So just a recap of points to keep in mind, and like I said, not completely red flags, but also some pearls from mistakes. So that I'll end my presentation. Thank you.
Thanks, Akshay. Great points. Just a couple of things. I think we are okay with time.
Yeah.
So is Rashmin there? Then I thought that he wanted to leave for the next one. So if there are questions for Akshay, we would be very happy to take them now, because I wanted to ask on the ICE test. So
Yeah.
So the question I had is, it's great to rule it in. But it's also a little bit of I think, because a negative one, you really can't do much.
Mm-hmm.
And I was a little, this thing about this 2 minutes and 5 minutes is something which is a revelation for me, I would say. But otherwise, how does it actually work out? ICE test generally.
So like the sensitivity, the positive predictive value of an ICE test is extremely high. And we've actually done the study which we published about all patients with myasthenia who present as unilateral ptosis were investigated on ICE test, anti-acetylcholine antibodies, and neostigmine test. So and of course we presented an algorithm of what if it's a patient below 40, above 40, with a prior history of ocular motility disturbance or the first complaint. So if the ICE test is negative, the next best thing to do is to do an anti-acetylcholine receptor antibodies. And the combined specificity of both is close to 95%. So if both are negative, then you virtually ruled out myasthenia.
Any other questions? Ganga, any points? Please.
You have a clinical suspicion of myasthenia, you go for repeated nerve stimulation test, or you go for antibody?
I go for antibodies, and even then, if I have a strong suspicion, I actually give a therapeutic trial, which is starting with pyridostigmine, Dystenon, Gravitor, 60 milligram in an adult thrice a day, and an elevated step ladder of oral steroids, opposed to what we traditionally do of a tapering. Here it goes in a step ladder increase, and then call them back at say 6 weeks, which by then is a good idea to understand. And if a therapeutic trial has still failed, then it's probably not going to be myasthenia.
So good morning. You have such experienced faculty. So I just like to know that, do you have any experience with CPO, with superanded senile ptosis?
Yes, ma'am. CPO also we presented last year of, so aim in CPO because of poor bells is just to undercorrect, and we traditionally go in and do a little bit of a sling usually. But sling, having to lift a floppy, loose, thinned out sling may, in with coexisting senile ptosis, can be difficult. So a few patients, when we actually went, because they also had severe dermatochalasis, we had to correct like a mini bleph for functional purposes, and that's when we actually saw the thinned out levator. So
So do you do it in one go, or you go stepwise? And because I had a patient, and the whole family of CPO, I operated on the mother, then the son, and the mother, of course, was 80 plus, and she really was disabled because of her droop. So I did it stepwise. I undercorrected, and then she wanted some more, then I did some more, and I didn't do much. I didn't do sling for the mother, but for the younger son, he used to stay in the hills. So he said whenever he would drive up, he had a lot of difficulty in seeing, and he was a very active businessman. So I had to do sling. So that also I undercorrected. So this is one very challenging situation.
yeah.
CPO, the main issue in CPO is that elevation is also a problem, closure is also a problem. So there is a technique described where we do a tarsal transfer from the upper lid to the lower lid. In that way, we shift the palpebral aperture superiorly. So what we need is functional vision, which is absent in CPO. So what that does is we shift the tarsus from the tarsoconjunctival graft, take a graft from the upper lid to the lower lid, and that actually shifts the palpebral aperture, and they have very functional vision. For central vision is good, and aesthetically, of course, because it's a shortened tarsus, aesthetically it's not that great, but functionally the patients are very happy. So I've had I've done about 8 to 10 cases, so they're all doing well. Sometimes we have to revise on it because sometimes it doesn't scar as well. We want the upper lid to scar, so it doesn't scar as well, so we may have to go in again to just do a small another excision and then again closure, but usually most of them settle down well. It shifts up, but it shifts up just in case thing. So usually the patients adapt because they are very happy with the central vision. Patient adapt and they adapt their reading distance and everything to bend their head, and they're happy with it. So they're more happy without because their central vision, everything, all their daily activities can be done.
The facial nerve weakness in myasthenia and in CPO is more important. I had a patient with facial nerve weakness. I did a sling, but then I had to loosen it. That was the only case that I had to loosen the sling by cutting the sleeve off. But the lid is remaining in the upper position. But still, because I think facial nerve weakness is one even when we examine, we should look into. Myasthenia and CPO,
Right.
more than Bell's and Sharma's.
Right.
The CPO discussion is good. Actually, I wanted to ask, is it because essentially, like, you basically have to clear the visual axis. So between, let's say, a tarsofrontal sling with a silicone, which I guess would give you a little bit of a reversibility because there is a significant risk of exposure, versus a levator surgery, or let's say a tarsal transfer from upper to lower. Are there any preferences of people in the crowd, or?
I think I have been loyal to a silicone sling.
So we published a series on frontalis versus levator exclusively in MED. And there what we found is that levator gives you a little bit of undercorrection. Frontalis gives you a better height. But the height of frontalis is not sustained. So eventually in follow-up, your frontalis will end up at the same level where your levator is. The amount of lag ophthalmos that we got in patients where we addressed the levator was lesser than the frontalis. So eventually, whatever surgery you do, you're going to end up at the same level. The most important part though was that in patients who had levator resection, the result was very, very long lasting.
frontalis required multiple revisions over a follow-up period, and we only included patients that had a very long follow-up period.
I think soon we'll have frontalis flap also in the game now.
Yeah.
with more
And just
people
was, so I think the key thing could be also, particularly in CPO, could be the how good is the orbicularis function.
Right.
That could be a deciding point. Thanks, Akshay. Thanks a lot.